Welcome to the New Vision podcast. My name is Darren Bartlett, and I'm going to be taking you through this session here. Where we're going to be talking about one of the killer diseases we've talked about for a very long time here in Uganda. Since I was a child, I've heard about malaria. We've talked about cerebral malaria and a couple of things. So it means that there could be more types of malaria, but that's not for me. I'm not an expert to talk about malaria. And that's why in the studio today we invited our one and lovely Crystal Virungi, who has been here before, by the way, when we're talking on Urban TV, then we're talking about Urban Doctor. And she talks still about malaria. But you know, every single year, medicine changes. There's a lot of technology that goes on. Even diseases evolve. What we knew then could change up to date. But without saying much, ladies and gentlemen, I introduce to you Crystal, who is right here besides me on my right here. Crystal, how are you doing?
I'm doing well, thank you.
And
Darren.
Welcome.
Thank you. I'm glad to be here.
I'm happy that you can take off some time to come and educate us on a couple of things, especially when it comes to diseases that we are worried of. We have kids out there, they fall sick, people neglect sleeping under the mosquito net. By the way, even when they sleep under the mosquito net, is it treated or it's not? Or just one slight mistake and the mosquito is in, people fall sick. And we said, let's talk about malaria. And you're the only person that I know in my head, the only person that I know who can talk about this subject at a conclusive, not only conclusive, but I mean at a satisfying end, so that whoever is watching us and listening to us is able to make a better decision. One, to make sure that they seek for medical attention, but also two, how do they prevent catching the disease, the deadly disease of malaria, but also three, to understand where are we going with this, because I know that there is an SGD to kick out malaria by a certain year, 2030, if I'm not wrong. But welcome. Say hi to our people.
Yes, hello, my name is Birungi Crystal. I'm an entomologist at the Uganda Virus Research Institute, where we study a number of disease-transmitting insects, including the Anopheles gambiae, which is the malaria transmitting mosquito that does most of the damage here in Uganda.
You know, when you talk about malaria, and I'm thinking, you've mentioned a profession that I cannot even say again in my mouth, but I'll leave it to that because I know at least you're an expert in understanding what this is. But one would want to think there are so many diseases that you could have specialized in researching about. There's cholera, there's Ebola, there is polio, which we are fighting to kick out of the country, and so many more. But one would think, why did Crystal decide to specialize in malaria? Why malaria? Why not the others?
Let me tell you, there, no one is more motivated to fight a disease than the person who is affected by it. And very many people in Uganda, growing up, malaria was really a problem. And by then, we're not fortunate enough to be among the wealthy. Unfortunately. So many times we could not really afford, these malaria drugs. And the mosquito net was a dream. It was something you found in rich people's houses.
It was a rumor.
it was
person's home.
Too expensive. So malaria was a frequent visitor in our house. And when you yourself fell sick of malaria, most Ugandans will say that is normal. We all get malaria.
Musuja.
We get sick. But it is different when you watch someone else
having malaria.
So something for me which really just determined my whole life. I have a younger brother, and he used to get seizures. Some people here in Uganda will know that some children, when they get malaria, they get those seizures.
Okay. And
he was so tiny, and he would get these seizures the whole night. And I remember watching my mother, she's trying to wipe him, keep him cool, keep him cool. And you look at him and you know there's medication for the disease.
Yeah,
and you don't have the money. So what are you going to do? You're going to pray. You hope that he'll be fine. You just pray. That was the treatment. Because we had no money. So he is having the seizure. Your mother is wiping. She's worried. All of you are worried the child is going to die. It was really not a nice place to be. And you're like, this is not fair. Because you see, if that little boy died, it would be because of where he was born. Because you are born in a place with malaria and parents wouldn't have the money to treat it.
True.
And that is not fair. That should not be the case. It should not be okay. So there are many Ugandans who still think, malaria, yes, some people die, but that is life. No, that is not life. And so I thought we should be able to change this. We should do something. So when I was about in S2, there's a program that was started called the Global Fund. The Global Fund is the organization that pays for almost all those mosquito nets and drugs that
The
we have
one-
in our hospitals.
The ones that are given
They're free.
the free mosquito
The free
nets.
ones, the free mosquito nets. And so the first mosquito net, in fact, until I finished university, the only mosquito net I ever owned was for free, given by the government. We did not have money to buy mosquito nets, but we got those
Crystal.
nets.
Okay.
It was the only one. And then they did this thing called village health teams,
Okay.
where they got people in certain communities. They trained them, the VHTs, and then, especially back then, they would give them like drugs for malaria. So they could diagnose and treat you there in your community. So even if you could not make it to the hospital. And then let me tell you the difference this made. Of realizing these diseases were like, oh, that's life. No, it's not life. You
No,
can
it's
do
not.
something.
It's not
And when
normal.
you do something, people live.
Yeah.
So these are preventable deaths. And I decided that's what I wanted to do something about.
Okay.
Which is, lo and behold, I go to university, I study entomology, looking forward to get rid of
Entomology.
these mosquitoes. Yes, entomology to
Entomology.
reduce those mosquitoes, like target these mosquitoes. And I end up at the Uganda Research Institute at a project, very innovative, that is working on developing genetically modified mosquitoes with gene drive to reduce mosquito spread, those mosquitoes that spread malaria specifically, and therefore reduce malaria.
Have you made any achievements in it?
Yes, we have made some progress. It
As
has
you as a
been-
person, because that's what
me
you
as a
bring.
person, of course, even me as a person.
Yeah. Okay.
So,
you can combine them.
Yeah. So when you're studying how to reduce mosquitoes,
Yep.
you must understand the mosquitoes that exist.
Yep.
There are over 3,500 species of mosquitoes in
Really?
the world. Over 3,500. But here in Uganda, there are about 3 that are spreading all the malaria. Just 3 species, spreading almost all the malaria we have in this country.
Okay.
And of those 3 still, there's still a major culprit.
Okay.
Like the one that is the most efficient.
Which one?
Called Anopheles gambi. So, before you can have your tool to reduce these mosquitoes, you must first confirm what is doing malaria transmission in these areas. Do you have the right species? How does it behave? Because now you want to target it. What is it behaving like? Because that affects how the tools work. So for example, if you have a mosquito that is biting outdoors, then you deploy mosquito nets. Yes, they are good, people will sleep in them. But when they go outside, the mosquito will bite them and malaria will what? Continue.
They'll get it.
Yes, so we did what we call baseline, studying what exists. And we're able to discover that indeed the areas we're targeting, the major species that is spreading malaria remains Anopheles gambi. We're able to see the changing, where the behavior differs from what we thought, like maybe where the biting hours now are earlier or later. And we're able to find where they're still effective. We've also done insecticide resistance studies across the country. That is a Ministry of Health program, by the way, that the entomology department in Uganda Research Institute does. We keep track of insecticide resistance around the country. What that does is it allows the government to know what to deploy where. Because you see, if the insecticide is not working in this region, then that means you better look for a different type. You could come and spend all your money. You spray all those houses and nothing happens, right?
You mean there are different
There are different
regions that
insecticides, yes, for insecticide residual spraying.
Okay.
And they work in different ways. So
In
sometimes
okay.
mosquitoes will develop resistance to one or the other.
really?
An example, we found quite a bit of resistance to DDT in a lot of places.
Yeah. That was
And the reason
DDT
for
at
that
time,
is
yeah.
because back in the day, DDT was used for agriculture. So there are places where they sprayed pests with for DDT.
Okay.
But remember, the mosquitoes are also there. So
Yeah.
those that survived got resistant to the DDT in some of those regions. So now a region like that, you would know that is not even an option, even if you wanted to use it, because the mosquitoes will remain. So some of that is the very key information, insecticide resistance. There are places where we found mosquitoes were biting in the pit latrines.
Yeah.
They were hanging out in the pit latrines, not in the houses.
Yeah.
So you spray your house, you weave the net, but there's still malaria. So what's happening? The mosquitoes have migrated to the pit latrine because they can no longer survive in the house.
Okay.
So information like that is very vital to ongoing malaria control programs. But it's also vital to the development of our tool, because if you're looking for to reduce mosquito numbers in the wild, our tool will work through reproduction. So the modified mosquitoes must mate with the wild type. Yes,
Let me ask it this way. No. It's very important. Because you even talked about the type of mosquito. You called it an Anopheles what?
Gambi.
Gambi.
Yes.
In the science that most of us who have been privileged at least to go through school, I don't know if that's what you call it, but it was a female mosquito,
yeah.
Anopheles mosquito.
Yes.
Is that what you call Gambi?
Yes, so malaria is only spread by female Anopheles
A
mosquitoes.
female Anopheles mosquito.
Because
is that what you
only
call Gambi?
female mosquitoes
True.
bite.
Okay.
Now, Gambi is a species within Anopheles. A female Anopheles mosquitoes, there are many types. There are now many types. There are still many types.
Wow. Is that what
But
you call
among those many types, you're looking
Okay.
like 30 different types.
Okay.
There is one that is now a female Anopheles Gambi. It is almost like if you had a tribe and then a clan.
Oh.
Hey. And then there is
I am a Muganda or Wenchima.
that kind of thing.
Okay.
But in this case, the way mosquitoes work, those subspecies tend not to interbreed. So they remain, they look the same.
Okay.
Sometimes they can look the same.
Okay.
Like Anopheles Gambi still has even still more. Now if you imagine if you had a clan, now they are families. It can be complicated, but the truth is,
Okay.
they will not breed with each other. That's the important thing to remember.
They don't breed.
They don't
among
breed with each other.
Okay. Okay.
So you can target one. If
Okay.
you're using breeding, you can target just one because they don't breed with each other. Yes. So imagine if you had now within the kingdom, you had the clan, then within the clan, you had the family. And that one family is the one causing all the malaria. Out of all of the people you have, just that one family is the one that is leading to over 16,000 people dying in Uganda in a year. So that is the one now you want to reduce the numbers of. So that Anopheles Gambi is that one section within Anopheles. So you say female Anopheles, it's very broad. And some of them may be able to transmit. But what's causing it in Uganda here, doing most of the transmission, is that one female Anopheles Gambi.
Wow, quite interesting.
So what we want to do is to genetically modify it, which means to change it, like on a genetic level. And what we are targeting
Change what?
specifically.
The mosquito?
Yes, but only one thing about it, and that is how many eggs it lays. The rest would remain the same. It would look the same. Everything would function the same. We're only targeting a specific thing, which you can do when you're using genetics. And that specific thing is how many eggs does that mosquito lay? Because a mosquito can lay up to 300 eggs. Every single time it bites you, it only has to mate once. It's not like a human being. It only has to mate once like this. And then after that, it will bite you, lay eggs. Come back and bite you again and lay more eggs. And bite you and lay eggs. That's how it works.
So wait, it bites you.
And uses your blood.
So it's your blood that enables it
to develop the eggs.
to develop the eggs.
Yes.
Oh.
So actually,
Okay.
your malaria transmission is just a side effect. It's because it will bite you with malaria, bite
We are-
someone else with malaria, without malaria, and transmit.
We
But
are
its
a
goal is
process
to get
of
the
reproduction.
eggs. Exactly. It just needs that egg, that blood.
Blood for it to be able
develop
to.
the eggs. That is why the male mosquitoes don't bite, because they don't even have the right mouth parts. Only the female mosquitoes bite to develop their eggs. But that one mosquito will bite you and lay up to 300 eggs, and then come back, bite somebody else, go back and lay another 300 eggs. Within a week, you can have an adult mosquito from an egg. So the rate
The
of
cycle takes
multiplication,
about like 5 to 6 days.
it can take 5 to 6 days, and you have your adult mosquitoes if everything is, if it's nice and warm and they have the conditions.
The environment is okay.
Yeah. So mosquitoes multiply at a very rapid rate, which really makes malaria control difficult for us countries where we are tropical. Places where they have maybe a lot of desert or snow, you can have a period where the mosquitoes are not there because the environment is so harsh. And then maybe you can target in that time and achieve elimination. So some countries have had those kind of advantages where it's very dry or it's very cold and they're able to control malaria a bit better. But us here, it is tropical all the time. In fact, if you look at the top countries that have malaria, they have our similar environment. Nigeria,
We
DRC.
we have about only 2 seasons.
Yes, but at any given moment, Uganda is comfortable for mosquitoes, even when it is dry.
Whether dry or.
Because think about it. In Uganda, it will rain and then the sun will shine on the same day.
Yeah, on the same day, true.
Mosquitoes love that because it rains, the water collects. The sun shines, the eggs hatch. Other places, they'll have continuously bad weather for a long time. But here we have good weather, which is good. Unfortunately, it's also good for mosquitoes.
So let me ask this, because I mean, coming from a place where parents were very traditional, I know school was very important to us. We studied basic, that eggs are laid on stagnant water. And that was too basic for us. But in a person who's, okay, the people who are watching us, some of them think that malaria is seasonal. And I don't know which one is the season where we get most cases. Is it in a rainy? Is it in a sunny seasons? Because now you say it can rain in the same season when it.
Yeah. So in many parts of the world, malaria is very, very seasonal. But in Uganda, it depends on where in the country you are. Now, over 90% of the country. So in other words, when you remove things like Karamoja, where it's very dry.
Where it's very hot.
Or maybe like a mountaintop, like the few 5% areas where it's not
Mount Rwenzori, Mount Elgon, Wanale Mountain.
But for the rest of us, 90% you're at risk all the time. Why? Because even when it's very hot, you still get some tiny bits of rain and enough water here and there for the mosquitoes to survive.
To lay their eggs.
But what I will say is that there is a malaria peak.
Okay.
When it is in the rainy season, and now you have a lot more pools everywhere, the number of mosquitoes rises.
Will rise.
And that will usually trigger an increase in malaria cases. So while we may have malaria in most of the country, at any given moment, your child may get malaria. If they fall sick and they get a temperature, even if it's a dry season, most of our clinics, the first thing they'll test for, malaria.
It's malaria.
But in the wet season, now the clinic can be overwhelmed because they get so many cases. Because now it's more, it's a peak of the disease. So yes, there's a bit of seasonality to it, but there's not zero risk. For us here in Uganda, we don't really have zero risk. But that is some of the challenges for places like Karamoja, where it has historically been dry. They have one very short rainy season, predictable. So malaria is not something they worry about too much, But now with things, things have been changing. You've been hearing that. So sometimes, in fact, I think, was it last year or so, Karamoja is receiving more rain than it used to. In certain times, it's not expected to be a rainy season. They get more rain.
Yeah, like we just went through July. Okay, looked like summer. August looks like summer,
but the rain is rain.
Yeah, but it rained.
Now the challenge for places.
So the same for them.
Is that first of all they have less exposure to malaria than you, because it was rare, because the environment is not so conducive.
It's always hot.
Season. Now that means people who have never had malaria are getting malaria and they're not equipped, because they get sick faster, and the health centers are also not used to dealing with the few health centers they have. May not be used to dealing with all these large numbers of cases, so resources. When things are unpredictable, it makes it hard for the government to plan.
Sure.
And that challenges the existing methods. Because the government may say we're deploying nets in, we know it's going to start raining in September, October. So we shall deploy in August, so that by the time the numbers of mosquitoes rise, people have nets. Lo and behold, it rains in July.
Yeah.
You see?
Yeah.
So that becomes a challenge for malaria control.
Yeah.
Because now the government is trying to plan. They've planned when they're going to deploy, but the weather has changed and things are changing, and it is challenging the existing tools.
Let me actually ask you this one, because if you talk about change, truth is that the weather has changed. In January it was raining. We didn't know January for rain. In fact, January to March it was hot. Now, you can't tell when it's going to rain or not. Does the same happen for mosquitoes? Do they evolve? Does something change about them? Because
so what could happen with mosquitoes is now the species that we have that spreads most of the malaria it really likes rainy weather, when there's a lot of water available for breeding and when temperatures are not super high. It prefers that kind of weather. So when you have more of that weather, you're likely going to have more of that mosquito. Because it will just breed more and more. However, if it gets really dry, sometimes mosquitoes will, there'll be some evidence of estivating where they just rest. And then they lay eggs, and the eggs in damp places, and they rest, and then once the rain comes back, they become active again, and then the population increases. However, we also have some other species that like dry weather. So
in malaria family?
Yes, that still spread malaria. So sometimes if you see in some areas, maybe not here in Central, but let's say like maybe some areas of Tanzania where they've seen places become drier over time, and then they get that species coming up. Coming up faster. The Arabiensis, it's a Anopheles arabiensis. It's still in the Gambi family. So target malaria, here in Uganda, a major interest is that Anopheles gambi, which is the most common. But the project is targeting, like I said, 3 species. And one of them is that Anopheles arabiensis, because we know it also likes to compete with Gambia.
Yep.
So there's also research happening on Anopheles arabiensis, and the last one is called Anopheles colutsai. They're all in the Gambi clan, different families. That colutsai is really only in West Africa. We've not found it here. But in West Africa, it's major. It's major with the Anopheles gambi.
That's quite interesting.
Yeah.
Let's get into malaria. Okay, we're still talking about malaria. Now, back in the day, I don't know whether how you call the normal malaria here, but there's one type of malaria that I used to hear about called cerebral malaria. So if it's not cerebral, I don't know what it is. What do we have types of malaria, and do they affect people differently, and how do you distinguish them?
We do have
traditionally they just say musuja.
Yes, so for malaria, not all musuja is malaria. I think musuja was for fever. So you have a fever.
Musuja.
Fever could be caused by malaria. But if you're looking at malaria, so
Yep.
cerebral malaria is not a different type of malaria. It's a progression.
It's a
progression.
Okay.
Like the regular malaria,
Okay.
all the parasites have gotten to affecting your brain.
How does it get there?
It is just a lot of multiplication within your system. Like the parasites multiply and you get to a certain point where now they start affecting parts of the brain now. And that means, and that unfortunately can cause actual brain damage in some people.
Wait, are you saying that it's possible for someone to have malaria and it progresses into cerebral malaria, which can easily damage?
Yes, it is possible.
Without being noted?
And usually
Or it's noted, but maybe...
you'll have been sick for a while. Like,
Oh, you made...
yeah,
Okay.
you will have been sick for a while.
But you didn't know?
Either you didn't know or you just did not respond. So sometimes you're just unfortunate that it goes in that direction. But malaria has many, presentations in its severe form. So cerebral malaria is a severe form now of malaria. If it has not worked, it has progressed, and now you're getting brain damage. But there's also gangrene. You know gangrene? Where parts of your body can die?
Yep.
So malaria can kill so many blood cells. They start blocking your vessels. And so you end up with no blood flow to your legs or to your arms, and in those instances, then it will cause death or cell death, and they have to chop them off because gangrene. So that is a severe form we don't usually see in Uganda a lot, and the reason for that is you really have to have very bad immunity to get that. Like the malaria has to be severe, and in most cases here, the poor who have malaria that severe are very young. Very little children, and those ones will usually not survive amputations. You're going to amputate a baby's legs
Because of malaria?
They will usually not survive. Yes, it can happen. They get the gangrene in the legs are now useless. So you don't get a lot of that progression. You'll see it more every now and then in foreigners who can get malaria.
Yep.
Maybe they're not aware they have it.
Yep.
And then by the time they realize it has progressed and caused these issues. Because for them, they have zero immunity. So if they're adults, they've never had malaria, and they get it and they don't realize and they get treated, then those ones can find themselves, unfortunately, with gangrene and having to be amputated. And there's actually a very inspiring malaria advocate that happened to she from Australia.
Well, you know, when you said that, I have seen instances whereby, for example, if you want to go to the UK and they are telling you must have had either a malaria dose or something like that. Does that mean that there are regions in this world where you never get to hear about malaria?
There are places where malaria...
Because by the time you want to go to a certain place in a certain country and they're telling you, oh, you must have first take a dose of malaria. Does that mean that in those areas you don't get, so it becomes an African thing?
Usually.
Or people in the tropical regions only?
Yeah, no, so there are some countries where malaria has been eliminated. If you go back far enough, there was malaria in Europe. But remember, they have winter. So they have times when they can target mosquitoes and they know there are very few.
And kill them.
Yeah, and kill them. So, and they did historically. And because of winter, their environment protects them a bit.
Okay.
From the malaria spreading mosquitoes that are really good at doing it. Which is why, for them especially, the climate change is a concern. Because now we are getting something called invasive mosquito species. There's a species called Anopheles stevensi. That species is from Asia. It is known for being in cities in Asia. It spreads malaria. Wow. But recently it has been spreading. It has been found in many parts of Africa, including in Kenya.
Oh, really?
Very near our border already. And even in West Africa. So that species is more adapted to cities. You know how we were discussing a bit earlier that people in Kampala don't get as much malaria?
They don't, yeah.
Because the environment is not so good for those mosquitoes that spread malaria.
Yeah.
Now, if that species made it to Kampala, Kampala would be home. Because it survives well in rubbish, in dirty water, in sewage, which the other mosquitoes don't. And it is more resistant to insecticides. So we don't want to get it here. But, the world is now global. And with climate change allowing these species to migrate, that now becomes a worry, even for countries where malaria was limited a long time ago. Especially because they know their people now have no immunity at all. It would be like a baby getting malaria. They'll get very, very sick. So when you're traveling in some of those countries where they don't have malaria, it is wise to take a malaria dose yourself, or to check at least that you don't have malaria, because when you get there, they may not recognize it.
Oh, when you fall sick, you may not.
Oh. So, and they'll send you to a specific hospital that deals with tropical diseases, and you'll be under quarantine. So if I were you, I would just take the drugs.
Now it makes sense, because I thought that there was fear that when you go, you may transmit.
They don't fear it as much because they know they don't have so many of the vectors that spread the malaria.
What do you mean vectors? You mean
the mosquitoes.
Oh, okay. The type
so
of
they might have those mosquitoes in plenty. So if you go with your malaria, you may not spread it so much. But if they catch you, they will quarantine you still. Like they know now you have malaria, they quarantine you to be sure you're not. But they don't worry so much about that. It's the other way around. When their citizens are coming here, they'll tell them, keep taking this drug.
Keep taking this
drug.
Because
malaria,
you
have no immunity.
Okay.
The chances of death are very high.
Okay.
Yeah.
That's quite interesting there. So, I'm just going to go back to a point where I asked whether there are types of malaria, and then you said here malaria is just advancing, and that's when it gets to a point where it's damaging your brain and everything. But I have not, and I don't know, maybe I am lucky not to have witnessed these things. Since the 90s, I've not seen many malaria patients. Is it me who is seeing poorly, or does the disease at some point evolve?
No, it is you who's seeing poorly.
It's me who's seeing poorly?
Yes.
Where are we standing?
So what happens?
So where? Because I don't.
Where are we?
I see more. I see more bacterial infections. What people are calling bacterial infections. But I've not seen many malaria cases. But it could be that I don't go to the hospital much. But
so
has it evolved as well?
So it's a combination of where you are, and then also there's been a little bit of change in terms of the severity of malaria, or the percentage of malaria cases in places like Kampala.
Okay.
If you look at the map, say 2006 of malaria, how bad malaria was in different
about
parts of the
19 years ago.
Yeah, you will see that Kampala was really bad by then. But if you look at it from 2015, let's say 2015 there, the percentage has reduced. It's not zero. We're still at about maybe 5 to 15%. But it is not as bad, the number of cases within the city. So if you've been within the city, you may not necessarily see a lot of cases. But at the same time, malaria is an acute disease. So by the time someone gets a symptom, the first symptom, they will then get sick. So they have to take the medication. But then once they get the medication, as long as you have access to medication that is working, within a week, someone is cured. While for bacterial infections, someone may be sick for quite a while. So they may have more opportunity to really talk about it.
All right.
For malaria, unless you meet them the day they have been diagnosed, if they survive, then you could find that by the time you meet them, they may not mention, oh, I had malaria. And also because people feel like they understand it, they've always had malaria, they may not talk about it a lot. But the truth remains that if you look at just last year, Uganda still had about 13 million cases of malaria and over 16,000 deaths.
Oh.
So the disease is still very much present, but it is improved.
Okay, so let's talk about treatment. I know we have some time there, but let's talk about treatment, because we've talked about malaria at least a bit at a point that now I understand. You've brought me actually up to speed, and some of our viewers here and listeners up to speed. Now let's talk about treatment. Back in the day, we had Kama Queens, we had quinines, we had Fancidas, and these are all type of medicines here, which I no longer hear. I don't know if Coatam is still even there to this point, but given the times and changes of seasons, temperature, weather, climate change, and all these other things there, have we also changed how we approach the disease?
Yes. So historically, the tools that have had the most effect on malaria transmission have been tools that target the vector, and then also the medications are also useful. But the vector, we had mosquito nets, and we've had that indoor residual spraying, where they spray the houses with long-lasting insecticide. And that has progressed a bit because of the challenges they faced. And that in the net side, you had the insecticide resistance affecting nets and affecting the spraying. It meant that the insecticide they sprayed today, now tomorrow the mosquitoes are surviving. I'm sure some viewers have seen that. Or you find your mosquito resting on the net. Yet the net is
it's supposed to be having what you call DT.
They had different, some they had some pyrethroids, some carbamates, not DDT.
What was it? I don't know, because they used to give us treated mosquito net.
Cyperhalomethrin, they just call them, like, but they're different types of insecticides.
You have a better name
for
than
the
mine.
nets, right?
Yeah.
And for spraying.
Yeah.
But then, over time, you see there's some resistance in some areas where it's not working anymore.
Yeah.
And for over 40 years, we had only the same insecticides.
Yeah.
Luckily, some new ones were approved. So now we have one, there's the dual action nets, which have more than one insecticide. That means if the mosquitoes in your area are resistant to one, the other one could work. But there's also some new insecticides, finally. There's some next generation nets, which are being deployed in some parts, and they're working well. Like, so if they know the mosquitoes here are resistant to what we had, then they can bring a different one, which is new. Then on the drugs, there's also been drug resistance. The parasite that causes the malaria evolves. So it gets used to, maybe if there's a target which the drug used to target on the, to recognize this is the parasite, target it and kill it. The parasite evolves so that target is no longer there.
Okay.
So a drug comes and does nothing to the parasite.
Okay.
So over time, they have to develop new drugs so it keeps working. That is why you had evolution from Fancida to the next drug, and now we are at the Coartem, which are just combined artemether drugs. So Coartem is a brand. There's a number of them that act the same way. And unfortunately, recently, in the last WHO report, Uganda is one of 5 countries where they found partial resistance. Partial resistance means the medicine is still working, but slower. Oh. Not as well. Okay. Which means now we have to prepare for full resistance.
For in case.
Eventually it will progress to...
Oh, it will... Okay.
Yes. So usually, what would be good is if we could eliminate malaria before we get to full resistance.
Okay.
So we don't have to, again, formulate a new drug. To now, you would hear people in the future, if we didn't eliminate it now, then in the future, people saying, oh, they used to take, the way you're saying, we used to take.
That we used to?
Yeah, but we don't want that because that's very expensive. We spend a lot of money on it. And also, there's no guarantee that anyone will also not develop resistance. So we need new tools to add to the toolkit while the drugs are still working. Otherwise, we risk going backwards.
All right.
Yeah. Quite times when you used to hear about malaria, when you used to have 100,000 people dying every year.
Yeah, there were so many. There were actually so many people that to a point that from tablets to injections to how you call them, IV something.
Yeah.
I don't know.
Second line now. That's you move to quinine.
It then moved to quinine,
which has quite a lot of side effects. But at that point, they're trying to save your life.
Okay. Okay. So I know that Uganda has a goal, or maybe the world at large. But I know that this is the gospel that I've had. That there is a target to eliminate malaria out of Uganda by 2030. How achievable is this goal, and where are we right now?
The goal was to eliminate malaria in the whole world by 2030.
By 2030, not only Uganda.
Yeah, but we are unfortunately off track. We made a lot of good progress until 2015, and then it kind of flatlined. And in
fact,
you
talking about 10 years ago?
Yes.
Have we?
Since 10 years ago.
We have declined?
Any progress. In fact, in some places, it has gone up.
The malaria
numbers, for the first time since we started fighting malaria.
Okay.
Numbers have now started going up in
some
places. Yeah. COVID was one factor. Okay. In that case, I think after COVID, Uganda numbers went up. This time they've declined since the last year. But worldwide, from the last report, you know, the 2024 report gives you 2023 numbers.
Oh yeah, they give you the numbers the year before.
Yes. And increment of 11 million cases. For the first time, it has gone up instead of down. And that really now, the good thing is that at least it raised the alarm a bit and said we need to do more because we don't want to go backwards. We're not almost there. We wanted to be almost there, but we're off track.
Yeah.
But now, luckily, we have a lot of new tools coming up because people have said, people
Okay.
have noted that stagnation,
Yeah,
and they've noted the challenges:
Yeah.
resistance to drugs,
Yeah.
resistance to insecticides,
Yeah.
maybe sometimes misuse. I said, what can we do? And so now is an exciting time a bit because we have new vaccines for malaria that have come up. They've been in development for decades, but finally we have a vaccine. We have medication available for babies under 5 kilograms. That did not exist. There was no dosage. So if you had, under 5 kilograms, that means from either premature to maybe 1 month, 2 months there. If your baby fell sick of malaria at that time, the doctors would be guesswork. Just figure out how to treat. There was no dosage.
Then?
Until until about a month ago, they would just figure out what to give your baby.
Wow.
So the risk there, of course, is drugs have side effects. So if they might give them the wrong dose, if it's too high, could affect the liver, could affect. If it's too low, the baby may not heal. So really, doctors had a hard job, just figure out how to treat this child when there's no approved dosage. But now there's Coatem baby for that category of
Coatem baby.
Coatem baby.
Is it the same as the Coatem that we knew?
It's the same owner, same company.
Same company, but different. Okay.
So it is, yes, it's still artemether mefentrine, but now designed or approved
specifically to approach this kind of
for that category of children.
Okay.
But we have to remember that none of these is a super tool.
Yeah.
The vaccines have their challenges, if I can say.
I was actually about to ask you, like, I've had a conversation about vaccines. So I thought that we just have 4 years or 3 years to, 4 years and a few months to say we bye-bye to malaria by the vaccines.
Unfortunately, that is not true.
That's what I thought.
That is the vaccines just cannot be a silver bullet. The reason being, they don't have the level of efficacy required for that.
Okay.
Not 100% or over 90% efficacy. We don't have that. What the vaccines are good for is preventing severe malaria in children. So the problem we have, in Uganda, malaria is the #1 cause of death for children under the age of 5.
True.
Most of them are dying from malaria. So the challenge, and that's about 70% of all deaths. So it means if you could solve that problem, you're decreasing malaria deaths by 70%. So the challenge there with vaccines is that they will prevent severe malaria. That has been proven properly. They are efficacious. They are preventing severe. So you have more time to treat this child, meaning they may not die. Meaning you reduce mortality rates. However, they are not that as effective as we'd like at preventing infection. So that means a vaccinated child could still get malaria.
True.
But you have time to treat, so a child is far less likely to die, which is especially important for people who are even in places where there's poor healthcare, or the facilities are far, or the parents are very busy, you don't have time to make lines all day, that kind of thing. It is it will make a very big difference in terms of deaths, especially for children. However, the infections are not gone. So you're still getting people infected. And then vaccines, we all know the challenge of adherence. It's 4 doses, where these mothers have to take their children back to the hospital. For those doses. And I hope they will. But we also have to think about the practicalities. We really hope they do, because it could make the difference between your child surviving and your child dying. Because it's treating your child for malaria when the drugs are free and they survive. And then not taking the vaccine, and then the child dies too fast to get treatment. Really, I think that should be something they should.
So do you think we shall make it to 2030?
To eliminate? If we put everything
because that's the dream. That's what we think it will be.
Into it, for example, target malaria's tool of developing genetically modified mosquitoes is meant to also plug some of those gaps. Because the idea is that if you're reducing the numbers of mosquitoes available to spread malaria, if you're under the net, you're protected. When you're outside the net, these mosquitoes that would have found you outside your net, they are very few. So if you get them below a certain number, then it's no longer viable to continue malaria transmission. They're just too few to propagate malaria transmission. So if you have that, and then you have the drugs to treat those that have malaria, you could wipe out that parasite entirely. Then even if the mosquitoes later increase, we don't care. There's no malaria to spread. That is the goal. So if we work together, you have nets protecting those sleeping. You have genetically modified mosquitoes reducing the numbers of the mosquitoes. Remember, we said one of our challenges in our tropical belt is too many mosquitoes. Nigeria, Congo, Uganda, our environment.
Central African Republic, up to Kenya.
Our challenge is numbers of mosquitoes. So, in fact, Kenya has less. That's why they had less malaria. And now climate change is causing them problems. And Stevenson is causing them problems. But yes, so you have people sleeping under nets, they're protected. You have genetically modified mosquitoes with gene drive, reducing the numbers outside to spread the malaria. You have drugs treating those that already have malaria and spraying where people sleep outdoors. No, Uganda is.
I agree.
Yeah. Then, if all those tools come together, and then vaccines to prevent deaths, we could eliminate malaria. We can do it, but we have to work together. And we need every tool. At least research has shown that. There's publications, they've done it. Malaria cannot be eliminated by one tool. It has too many different ways of changing. But if we do them all together, we can achieve malaria elimination. Which means, I think the important thing is to remember what this means. This means there are no more preventable deaths of children under 5.
Okay.
Because these are preventable. There are those things you can't do anything about.
Yeah.
Malaria is not one of those things. It is preventable, it is curable, but we just have some challenges. But we could do it. So when a child dies of malaria, it is a tragedy.
I was actually going to ask you, like, I know we're coming to the end of the podcast here, and you see, when people hear a lot of science, they think, how do I not get into a position where now I have to pay treatment for malaria or even lose a loved one to things? Because if we keep saying it's preventable, it means that there's something we can do as individuals, as citizens of Uganda, and maybe the world, because I mean, being an international platform that we have, that we're going to publish this kind of video, someone will ask, what do I do then not to become part of the statistics of those who are getting malaria or losing a loved one towards malaria?
Yeah, so malaria is definitely an African problem. It's a Ugandan problem. We're number 3 in the whole world.
Oh, really?
Yes, number 3 in the whole world, after Nigeria and Congo only.
So it's basically Africa.
We're number 3 in the whole world.
Okay.
Malaria cases, Uganda. So definitely we should all be a part of the solution. So while, let's say, we have our scientists that target malaria at Uganda Research Institute working on this genetically modified mosquito to reduce mosquito numbers, even you at home, there are things you can do.
There are some things we can do.
First of all, use the tools that are available well, properly. So sleep under the net. Make sure your net doesn't have holes. You can patch it, really. You can sew. There's a needle and thread. Do not wait for, do something about that.
Okay.
Make sure you don't have unnecessary pools of water around your house. Don't leave ditches, containers to collect water to breed mosquitoes.
Yeah.
Like, make sure you can at least make sure you don't have that stagnant water in your communities. And if someone is sick, falls sick, seek immediate attention. I have seen, Darren, this is my experience. I have seen a child die of malaria in a village because the mother waited 2 days. Instead of taking the child to the health center, she decided to first finish her work. She had some work to do, which you can understand. These people are, it is hand to mouth.
Yeah, the work is good.
But she thought she had time. So she thought she had time. She said, this child, it's fine, I'll take them, after these tasks are finished because I need the money. But there in those 2 days, her child died. And I saw this. I saw it. I don't know if the child was sick, but I saw her trying to carry the child after the child had died. And she told the story.
Wow.
It has just been 2 days, the child will be fine, but the child already passed away. So it is really important. I would want to ask people who are listening that if you fall sick, if your child falls sick, seek immediate attention. Take that time, because that money will not help you if the child passes away before you get the treatment. It will not resurrect your child. So first get the treatment, and then figure out the money things later. Because there was in that position where a mother had to choose treat or work. And there were days where supper may not be there, but the child was treated. The child will survive 1 day without supper. They may not survive 2 days without malaria medication.
Sort of there. I hope you guys had that, and I'm gonna leave it. I'm gonna give it some 2 minutes to talk to our audience there more on. Of course, you've told us what they can do, but you could have the last message about malaria, because I personally was hopeful that after a vaccine, that's it. It's a wrap. I thought that with the hotter it becomes, that's it. But unfortunately, we are not even sure about how the climate works. And also to understand that malaria can also work that fast. 2 days, I thought people would suffer for almost a week. But if you say 2 days, that means it works very fast to end someone's life. So, Crystal, you can, let me just give it to you, your last words on malaria here.
Yeah, so malaria is a big problem in Uganda. But I don't want us to think that all hope is lost. It is not.
No, it's not.
We are actually at a really a really exciting point in time,
Yep.
but also a challenging point in time, where we have all these new tools available. By themselves, yes, they cannot get to elimination.
Yep.
But together, there's a very real chance that actually we could achieve malaria elimination. But it's going to take all of us. It's going to take regulators. It's going to take healthcare workers, researchers, and even the general public to decide that we're going to kick malaria out of Uganda. We're going to kick malaria out of the world. The tools are available or they're being developed. We are really working on it. So let us have the commitment and the will to say no more malaria, no more our children dying, no more our pregnant women dying. We don't want malaria in this country. Yeah.
Thank you so much, Crystal Birungi here, who is a researcher and an expert when it comes to researching on malaria here. This is a disease that we've known for a very, very long time. And you know what? Sometimes it takes very few steps for us to take as individuals. If you don't want clogged water in your environment there at home, please remove them, because otherwise you're inviting what you called Anopheles
Anopheles gambiae.
Which we in our primary was Anopheles, a female Anopheles mosquito, but she said again there are clans to it. But you know what, the most important thing is protect yourself, sleep under a mosquito net. If it's torn, sew it. If it can't be sewn anymore, go and get another one that you can treat, and so that your children, yourself, you sleep under a mosquito net so that you don't become part of the statistics. But one thing we want you to be part of is the goal, and that goal to end malaria by 2030. My name is Darren Bartlett, and I'm going to ask you to download the Vision Digital Experience app, where you can watch this. If you've been seeing clips and bits and pieces there, download it so that you can watch the full interview, or go to our social media platforms, newvision.co.ug, that is the website, or New Vision Wire. Those are our social media platforms where you can watch this interview so that you can learn more on how you can prevent yourself from catching the disease that is malaria, even for your children there. My name is Darren Bartlett, and I will see you in the next one. Bye-bye.
New Vision TV. Stream smart, stream New Vision.